All right. Well, good afternoon, or good morning, or good evening, depending on where you're coming into. We are delighted to be back here again with another webinar. Today we have Dr. Raj Rajendram from the Moorfields Eye Institute and Tunde Petto from Queen's University in Belfast. Thank you both for taking the time to join us today.
Thank you.
No problem.
So as we've kind of gone through this pandemic here, and that's what started these webinars, we've kind of been learning from each of you and opportunities about what your practice is undergoing. So Dr. Petto, can you give us a little bit of a snapshot of what it's like today in your clinic?
So we still have very reduced footfall, so we can't be seeing as many patients as we used to see, which is not really a bad thing because we are able to devote some more time for these very complicated cases that are still coming through. We are using imaging very wisely, so we're doing less fluoresceins and more OCTs, OCTAs, color imaging to make sure that we're seeing everything, and the face-to-face time is limited in between patients and doctors. The patients who are coming through, they are more complicated than your average clinic because we are only allowed to see those patients who are very likely to require treatment. And so we really have to be always alert and think about the issues that these patients might face. And just to finish off, a lot of these patients are coming out of isolation or shielding just to come and see a doctor. So that a lot of the patients are very apprehensive and anxious about coming. I don't know if, Ranj, you find the same?
Yeah, for sure. You know, a lot of our patients are in that vulnerable group. So a lot of people with diabetes, you know, often control is an issue. They've got complications in their eyes. So yeah, they're apprehensive. Even the ones who we've wanted to come in, sometimes they've made the choice that they'd rather wait till things settle down again. Hopefully they are, and we can get back on top. But the same as you, today we are doing a lot more differently in terms of imaging and less face-to-face. So I've got to really thank all the Moorfields staff and fellows and consultants who've really pulled to do things differently. And, you know, technology is a part of that. So hopefully we can talk about this now.
Yeah, so it's almost in some of the other doctors we've talked to, we've almost seen this clinical trial that's happened without a design of how long patients can go between visits, because we've had this circumstance that's prohibited patients from coming in, and we're seeing either the effects of that in a positive or negative way. But how have you noticed the patients coming back with lack of treatment? Has it been demonstrable to their care, or has it been pretty stable? What have you noticed as they've come back?
So for us, it's been very varied. We're picking up a little bit more neovascular glaucoma cases in the last couple of weeks. The imaging staff and the nursing staff have been amazing of triaging patients over the phone or triaging patients based on just imaging and giving us the most difficult cases. I think the main issue is that when the lockdown, at least in the UK, will ease and patients will start being braver and come back, in a couple of weeks' time, we'll probably see more of an effect. But certainly very severe complications, fractional retinal detachments and neovascular glaucoma are on the rise at the moment. Ranj?
Yeah, similar. I think it's going to start increasing now. There's been a couple of referrals. A couple of the fellows were discussing with me yesterday, similar neovascular cases that need intervention. We did some imaging-based virtual clinics and, you know, things that severe NPDR, where they needed treatment in the fellow eye, we were more likely to get on and treat the other eye as well with sort of prophylactic, because, you know, we can't be sure when we'll see them. It's going to be interesting, and our service directors are looking at it now with everyone, you know, just in case there is a second wave, what are we going to do? So we've got to try and do as much as we can in these next few months.
Do you find that you're maybe more apt to give a treatment one visit ahead, because maybe I would do it next time, but I want to space it out, or I want to make sure they don't get caught in another shutdown and be without?
Yeah, I think so. And, you know, we've tried to space out, for example, the diabetic macular edema injections to 8 weeks rather than bringing patients monthly. They're not the best patients to hang around even for an hour in the clinic. So yeah, it has changed things more to fixed protocol. As you said, we're going to have a look at these outcomes, and hopefully for the diabetes, we should be able to catch up.
Sure. So as we continue the discussion, we're going to go ahead and put up some polling questions for the audience. So the first question here is going to be, in which diabetic patients do you routinely perform OCTA? So let's go ahead and see which one comes up here. I'll be curious to see if this changes as your talks go through, and we get to see different examples of how you're utilizing this in clinical cases. But if people go ahead and just choose the answer they believe, in which cases, on which diabetic patients do you routinely perform OCTA? And as we get that, go ahead, Luca will go ahead and broadcast these results. So as you're going to be doing a lot of educating here on people that don't have an OCTA yet. So that's always good to teach the value of that technology as we go forward. I think we have one more question before we go into the presentations. So which do you believe would be the most important feature in an OCA device? Go ahead and choose up to 3. And I think this will be interesting to see exactly where people fall on which features are the most important, because it's not always the ones that you think. And again, it's going to be a little tougher for the non-users to know which ones, but it'll also be curious to see which ones they believe they want to see. So as we go ahead and capture a few more of those answers. And then we're going to go into your presentation first, Dr. Petta. So go ahead and we'll start that in just a minute. But we're looking forward to. I'm going to go ahead and let's see the results here. So image resolution is number 1, which kind of makes sense because without good resolution, the rest of it probably doesn't work. But then it's interesting to see kind of where you'd like to see a lot of it, right? Segmentation, depth of scan for looking at the choroid are all fairly easy. But a strong number down the bottom, which I think I wouldn't have thought of originally, is the ease to interpret the reports. I think that's one of the key characteristics we'll come back and talk about after your presentations, I'm sure, about how we go ahead and utilize the different segmentation algorithms to really treat the patient. So I'm going to go ahead and mute my camera. But before we start the presentation, anybody in the audience with a question, please choose the Q&A button and put your questions in there. I do see a couple people mentioning that the audio is not working for them. It is working for others. I apologize. We will have an on-demand feature of this if it's not working with your computer. So I'm going to go ahead and mute my, my camera here, and we will come back and talk and discuss this as soon as we're done with the presentation.
Thank you for that wonderful introduction. And these are my disclaimers for today's talk. We are all familiar with fluorescein angiography and OCT, and we discussed a little bit about these techniques before, but where does OCTA fit in? OCTA, or OCT angiography, displays the vessels of the retina and really vague profiles of the choroid without a contrasting agent, which is currently, in the current climate, is extremely important both for the patient and for us to be able to keep looking after our most vulnerable patients. So OCT angiography works in a way that if there is a light of a single wavelength that's directed towards the retina, and the change in the signal is measured in the emergent light between sequential B scans taken at the same location at very high resolution of the passing blood cells in the different vessels. Therefore, it is processed to construct a map of blood flow, and it shows the vascular structures where there is blood flow through the vessels, and it's fixed in a point in time, as it can see in these images below. The flow is if the flow is extremely slow on one of the vessels, then there is no signal on OCTA. And it's the same if the flow is extremely fast, beyond what we can record. So the flow within the acquisition range will come from the decorrelation of signal on OCTA, and you will see a lot of these little red dots when you look at your OCTA images. These very much help you to be able to decipher where the vessels might be. So it's very important that you actually think about the relevant question that you need to ask, because otherwise you will not be able to appreciate the answer that the images are giving you. So how do we work it in clinic? We tend to take a standard OCT image, including the volume scan, then a macular-centered OCT-A, and you can decide which size do you want to take. If you have a very small abnormality, you might take the 3x3. A larger abnormality that where you really need to see the whole of the macular area, you will probably need to take the 8x8. And if you want to go further out towards the periphery, then you can add additional fields, especially if the pathology is eccentric to the macula. And you end up with a beautiful 12x12 image where you can see the vessels outside of the arcade, the whole of the optic disc, and a little bit to the nasal side of the disc as well. So when you're looking at OCT-A images, it is crucial that you understand the retinal anatomy. And we sometimes have to go back to real basics to be able to decode the message that OCT-A is giving us. We need to look at the entire retina. We need to examine how the color depth encoded maps gives us the information about flow and the vessels. And then we go from the inner limiting membrane all the way down to the choroid and look at the retina in all layers, including the RP and the Brooks complex. It's very much recommended that you always look at the unfair slab that's displayed simultaneously, so you know where you are on the image. And if we go from the full retina, that is on the left-hand side, beautifully color-coded, and then you can see that through the superficial and the deep retina, the vascular area down to the choroid, you are able to see all the vessels that have relevant amount of flow in them. And you can also see on the OCT as to which depth you are, so you are able to orient yourself in the images. So taking all of these issues in hand, we will be able to see how we use it in patients, such as this patient with diabetic retinopathy. So this patient was referred with a macular edema in the right eye and previously had bilateral factor emulsification and intraocular lens implantation 3 months previously. It says 5 years history of type 2 diabetes mellitus and has very good vision with 81 and 8 letters on a 6-meter chart. And if you look at the images, the color images that are montaged, then you will see that there are hemorrhages and also some microaneurysms in both eyes. When we look at the OCT-A images of the right eye, then we are able to see the small vessels around the foveolar vascular zone. And you can also see at the same time on the OCT slab where you are in the retina. So you're able to decide which plexus you're looking at. So when you look at the right eye skeletonized vessel map on panel A and the perfusion scan on panel B, you can see that on both you very much appreciate that the foveolar vascular zone is elongated and it's not a very nice circular shape. So while there are some changes in the foveolar vascular zone, however, the vessels around the foveolar vascular zone seem fairly perfused, and there is no obvious capillary non-perfusion in the vicinity of the fovea. That probably explains the good vision the patient has currently. And if you look at the different matrix, then you will be able to see that the vessels and also the perfusion map, you see that there is good perfusion around the foveal vascular zone. When we go to the left eye, then you will see that on the superficial retinal slab and the corresponding OCT-A image, there is reduced capillary density in the parafoveal area, And there is also pruning of the vessels. So the vessels seem to sort of stop at a given point without being connected to any other vessels. But on this image, there is no cyst, and that's the eye that was not operated on some time ago with cataract surgery. So even on the left eye, you can see that the vascular zone, foveal vascular zone, is larger than what you would expect, and it's very irregularly shaped. And in this eye, you can actually see some capillary non-perfusion. But it's for the uninitiated, or if you don't look at it very carefully, you might miss it. And some of these areas we will look at in a minute, much in more detail. But when you get the perfusion map, the blood vessel map and the perfusion map, you will see that there is a fair bit of capillary non-perfusion, these areas in blue. So based on these studies, we actually went ahead and did fluorescein angiography as well. And you can see that in the right eye, there is some patholoid changes, and there are some microaneurysms, while in the left eye, there is a much larger foveal vascular zone. And those areas that were blue on the OCTA, you can see that there is very little. So there is very little circulation on the fluorescein, and also that you can see some vessels that are coursing through an ischemic area, and you can see a hot disc. So all of these together mean that this patient is already in the middle of having some vascular problems with his diabetes, and we instituted high frequency monitoring for this patient, and because it suggested that the retinopathy might worsen further. So when we think about capillary non-perfusion, it's always very difficult to ask for fluorescein angiography. And we're simply not at the point, even in the COVID era at the moment, that we could be doing as many fluorescein angiograms as we would like to do. So I would like to appreciate this thought on this next case. So this is one of our patients who is just about to retire and had type 2 diabetes for 10 years. And you can appreciate the new vessels on the disc. And you can see that it's had a reasonable coverage with PRP laser, and despite that, there are still some new vessels on the disc. It's also on anti-VEGF therapy for diabetic macular edema, and you can see that there are still some cysts in the retina, but overall the retinal contour is relatively normal. So when we look at the left eye, though, this patient has been asked to come back several times to have the left eye monitored, and in the temporal area of the OCT, you can see that there are some suspicious vessels, and it has always been described as a questionable ERMA, and on the surface of an ERM. So. But the patient's vision was sort of slowly going downhill, and that's why we decided that we would do an OCTA. When you do the OCTA in the left eye, in the area that was in question, then you can see that there is a huge area of neovascularization. This front is very obvious on OCTA. It was nowhere near as obvious on the previous images on the OCT. But in the OCTA, you can see it very well. And now that you appreciate where it is, you can also see it on the color image. So the OCTA helped you to decipher where the new vessels are without the use of fluorescein. And you can see that it is developing, the new vessel complex is developing at the edge of the normal and the ischemic retina, the normal and the ischemic retina, and that these new vessels look active, and therefore this patient requires treatment with pan-retinal photocoagulation, or sometimes with anti-VEGF, whichever your treatment regime might allow you to do in the current era. So we did do the PRP, and you can see on the first scene that we were completely right. The whole neovascularization is surrounded by ischemic area, just as you could see on the OCT-A, large areas of ischemia in the periphery. And these ischemic areas, you can always see that the vessels, when they go through, they seem to stain, or sort of like this, they would have a minimal leakage. It doesn't necessarily mean that this whole area is new vessels, but the leakage comes from the sheer fact that they're going through the ischemic area. And unfortunately, this patient passed away in a myocardial infarct not long after the start of anti-VEGF treatment and the finishing of the PRP, pretty much confirming that he was a vascular path right from the beginning. So the next case will show us that it doesn't always have to be ischemia that causes the vessels to be leaky or staining a little bit. This is a 48-year-old man with an 8-week history of mild blurring of the vision. There is really not much of a cardiovascular history, and the vision is still very good compared to the fact as to how the eye looks, with 4-quadrant hemorrhages, dilated tortuous veins, and what you would describe as a potential central retinal vein occlusion with lots of hemorrhages. So the first scene angiography shows that there's a relatively good perfusion, and when we do the OCT-A, then you can see that that there is severe macular edema shown on the OCT image itself. So you would have to think about how we are going to segment this image, because sometimes when you have this much edema, then you really struggle to find the right layer in the retina, and you really have to think about resegmenting or changing the lines to make sure that you get the correct segmentation of the slab that you want to see. So the adjustment of the segmentation lines is usually quite easily performed by just moving the segmentation line and making sure that you are in the layer where you would like to be, and you segmented the layer you wanted to have. And then you can see that in this case, the foveolar vascular zone is normal looking. And you see on the unfast lab that there are a number of cysts in this eye, but the actual retinal vasculature looks very good, and that adds up with the amount of vision, the very good vision that this patient has. So just to finish off, I would like to just present this very last case that will be able to show us that it's very important that we look at the OCT, the patient, and all the images together. So this patient is a 75-year-old female with 1 year of blurred vision. And she also has vascular problems, as you might have imagined, and the history of treated hypertension and angina. And the right eye has poorer vision, but the left eye has very good vision. And in the right eye, there are a few dot hemorrhages, as you can see on this. And the RCT of that eye showed sort of a nondescript generalized edema in the right eye. And we weren't quite sure what the origin of this could have been. You can also see quite marked epiretinal membrane. The left eye had a normal OCT. So when we looked at the OCT-A of this patient at the relevant area, then you see that there are large areas of capillary non-perfusion and all over in this slab. And you also see the areas of spatuloid cysts in the right eye. And wherever you look at, you see quite a number of areas of ischemia. These areas are very central, and they explain partly as to why the vision is so poor, together with some of the outer retinal changes seen on the OCT itself. So when we commencing anti-VEGF treatment, the edema resolved, however, the vision increased to nearly normal, but not quite normal. The capillaries are better visible. It's always up for debate, as you know, if they do come back or just visualize better. But you can see that the areas of ischemia still remained relatively stable in terms of their size and location. So what have we learned from these cases? So when you're using just color imaging and spectral domain OCT, high throughput imaging clinics can miss key signs of ischemia and even proliferative diabetic retinopathy if they're only using those imaging modalities. Sometimes the severity of the capillary closure is not appreciated on color imaging, as a lot of patients at that stage have a featureless retina. So instead of seeing lots of abnormalities, you see like grayish featureless retina. And they can have very severe capillary non-perfusion, but not very many overt signs of the disease. Sometimes as the OCTs, you might see retinal thinning, but again, the severity of the ischemia might be missed. So OCTA helps to detect ischemia and retinal new vessels with high fidelity, especially if you think about your imaging protocol and make sure that you ask for the question of the area to be imaged. At the moment, we don't really understand absolutely everything about OCTA, but with the COVID, we also found that we're wanting to keep the patients in clinic for a shorter period of time, not wanting to do as many fluoresceins as we might have done otherwise, and with the patients appreciating that they don't have to have fluorescein angiography, we are doing more and more of this technique, and of course, we are learning more and more about it. Thank you very much for your attention.
That was excellent. Thank you so much for going over that. We do have a few questions from the audience, so if we could have your cameras back here, perfect. So one of the questions, first starts, and again, the segmentation was one of the questions that we were hearing from the poll results out there. So one is, what is the significance of segmentation on the OCT? But the question I also want to go with that is, in how many cases do you go through and change where the segmentation is happening different from where the algorithms give it to you as the straight segmentations from the device?
So the segmentation is important in terms of delineating the layers of the retina you're looking at. So you identify the RPE and the ILM, and then derive from that the rest of the layers. It's fine if you're looking at one of the anatomically perfect diagrams, a normal patient. Generally that works perfectly. But if the patients are coming to the eye clinic, then they've generally got a problem, such as macular edema, and it's pretty impressive how the machine can still, despite that, as we saw in those images, work out where the layers are and work out flow and which layer it's in. So it is important. We live in the real world with patients with retinas that are not quite normal. In terms of going through the clinic, I think one of the questions you asked in the beginning, or the response to the poll, ease of use. The clinics are busy. I would like to go around and sit on the OCT and adjust the segmentation, but practically in the clinic, you don't often get to do that unless there's a specific lesion that you want to identify. So we're heavily reliant on the quality of the automatic segmentation, which is, I have to say, really good. So it's rare that I need to do that today.
I completely agree. For most patients, the automatic segmentation is perfectly fine in a clinical setting. If you're wanting to make extremely detailed measurements and you're looking for a very small abnormality and it's a very damaged retina, you might have to do a little bit more manipulations. But for your average patient, it's great. You do, as far as I'm concerned, I still have to look at both the unfast lab and the normal OCT, just to make sure that I know where I am in the retina. And then also sometimes you have to think, have I asked the right question? And is the imaging answering me the question I wanted to think about?
Yeah, I always put it, when you start to dial in on the segmentations, you've become interesting to your doctor. And whenever you become interesting to your doctor, it's not good for your eyesight. So it's never a spot you want to end up. But I really enjoyed your presentation. That last talk where you showed the color photos looked pretty similar from left and right eye. But then when you really showed the OCTA, the ischemia that you got around the FAZ was not visible, I don't think, at all, in either the structural image or obviously in the fundus photo. So a couple other questions as we go through here is, can you confuse artifacts with ischemic areas, Dr. Peto?
Absolutely, especially when you start. You have to be, that's why I always say, that's why I emphasize, and we see a couple of other techniques in the next talk, but that's why I emphasize that you really have to be able to look at the OCT and the slab and the OCTA. You look at what other abnormalities you're seeing. If they're very big cysts or very big fibrous tissues, you really have to give a little bit of thought as to what you're seeing. But you will learn, and then also, the better your technicians are and the better the communication with the imaging staff, who's been absolutely amazing throughout the COVID crisis, at least here in the UK, and I'm sure for most of you as well. They will take the best possible image. It's quite rare that you have to go back and ask. But if you have a specific question, just do and double check.
So for this next one, we'll have you guys give your top three, because I think it's gonna be tough. So for which underlying diseases do you always perform OCTA?
Okay. Well, I'm not a big fan of never and ever.
I know,
because it's difficult to say if it's always. So we use it a lot in diseases such as diabetes and vascular occlusions, AMD, of course. And some of the diseases or some of the cases when you don't really understand why the patient has lost so much sight, and if you think that there might be ischemia there. Ranj, anything else?
No, just thinking of Kevin's poll at the beginning. There are a lot of people who don't have access to OCTA, and a lot of our work is retinal vascular disease, so it adds really. So I hope Kevin will work on bringing it out to more people, but certainly for all diabetic patients, particularly when we're starting or considering starting anti-VEGF treatment. I've got a case in the presentation, AMD, for sure. It's very useful, and as we like everyone learns more about it, we are more comfortable with just doing the OCTA. But so for AMD we do, and then retinal vein occlusions to look for ischemia. The wonderful thing is that we can repeat this at every visit if we want to, whereas the fluorescein, you do it at the baseline, and then patients often don't thank you for that and don't want it repeated unless you have to. So for those groups of patients, and they come back to us hopefully repeatedly, it's very useful to have a baseline and then compare down the track.
Yeah, so I always enjoy the questions we get and the people's names. I've done this now maybe 10 times, so I'm used to seeing some of these names out here. So Amy Goldstein, I'm just going to ask her question because she's up early in California. It's only 7:30 when she asked this question, and it's probably for me to answer. But which version of the software offers the FAZ measurements and perfusion maps? And while this is available in Europe under CE, it's not yet approved under FDA in the US, so it's still waiting to be released in the US. But you guys have the luxury of having that feature. But Is this something you utilize quite often, the FAZs and the heat maps that are there?
Yeah, I do find that the FAZ is great. I always used to look at that anyway. And then the heat maps are reasonably easy to explain to the patients. You know, green is good or greenish, and anything else is not that good. So if their vision is good enough to see colors and patterns, then a lot of patients still appreciate that kind of visualization. Ranj, do you find the same?
Yeah, I agree, particularly, you know, when you're considering starting anti-VEGF on a patient. It's all very well to say in this trial, this many patients gained, you know, this many lines of vision, but, you know, it's a long course of treatment, perhaps 3 years. And so, you know, if you can have that conversation early on in the treatment saying, you know, there is some ischemia here, we hope that macular edema would improve, but it may not, you know, it may take some time and it may not improve like the big headline trial says. You have the patient on board and, you know, you really need them to look, you know, at the best imaging you can get, we can get something information from that. But the patient also understands if you show them a normal FAS and an irregular FAS, they'll appreciate that, you know, it's still definitely worth trying for all of the patients, but some may not be in the 100% top, but it's still worth going.
Well, before I ask the next question, I want to go and put up our next polling question. So since incorporating OCTA, how much is your FA usage diminished? Has it gone down by 50%, 25%, 10%? Has it actually gone up? Have you been no change, or do you still have you not bought an OCTA device since we asked this question 20 minutes ago? Maybe the sales rep hasn't gotten to you yet. So we're curious, but so as they're answering that question, and then we're gonna, again, everybody put your questions in the question and answers during the next presentation as well, and we'll come back and answer them afterwards, but we'll ask one more. We can broadcast the results of this one here and see just how it is. So 50% was the biggest drop that it went down. So the question was, what percentage of patients of OCTA do you require a fluorescein angiography now in your practice? I didn't want to prejudice the polling question by you guys answering first. So tell us a little bit about how the FA has, the fluorescein has been affected in your practice.
So for me, certainly for the new wet AMDs that we see in the clinic, we're much more likely to get the OCTA and not do a fluorescein if we're happy with that. So I would say 30%, something like that. I think, so similarly for the diabetic macular edema patients, before we start treatment, we did want to get a fluorescein so that we can have that discussion with them and look for ischemia, but the OCTA is fine. So we do that a lot more now. So yeah, I think for them, probably more than 30%.
And Dr. Petto?
Yes, I think we probably went down even more, 30 to 50% for the diabetes cases, and very similar for the AMD cases. My major worry a lot of the times is that we need to look at the periphery, especially for diabetic retinopathy. So if someone has questionable new vessels far on the periphery, then fluorescein is at the moment still the way to go. But hopefully at one point we'll have wide field OCTA, and we can see that far periphery as well, and that would be great.
Great. All right, so we're going to go ahead and, Dr. Rajendra, have your talk. I am expecting Dr. Pizzamente, who's out there, to have a good question for this next session. So let's go ahead and mute our cameras again, and we'll go ahead and start this next video, and look forward to seeing you.
Okay, so I'm Ranj. Thanks for joining us. We wanted to talk about the Angio Ct Angioplex and why it's so useful for our practice. Thanks for Raluca and Kevin at Zeiss for organizing this. It's really useful at this time to be talking and discussing about cases. So here's my disclaimer. And we really want to talk about the use of Angio Ct in retinal vascular disease here, particularly talking about diabetes, proliferative diabetic retinopathy, macular ischemia. Peripheral ischemia, you know, why is it important for us to document that? Diabetic macular edema, and why it's important to do an Angio Ct in patients we're considering treatment with, retinal vein occlusions, and then other things. So we'll just talk through it. I think it's really important for patients to get a very good image I think the better it is, the more understanding of their condition and the more on board they are, which, you know, over the long term, which they'll be with you for. And then for us, you know, we want imaging and show patients whether things are progressing, what their response to treatment is. So here's a patient with diabetes, typically we see with the Claris. And it's a good record. We, some time ago, would have done a fluorescein, but we can see some details here, some vascular abnormalities, cotton wool spots and such. And with the Angio Ct, we can do a montage. That takes us out pretty wide to the mid-periphery arcades. We can see some capillary dropout, some vascular abnormalities. And the good thing about the Angio Ct is we can repeat it at regular visits. And we compare it with a fluorescein. You can see similar features, the mid-peripheral ischemia, vascular abnormalities, but the fluorescein is something patients just want you to do the once, not repeated, whereas with the Angio Ct, we can repeat it and monitor. So the other things to look at are proliferative diabetic retinopathy. This is always a question for us. When do the new vessels start? Are they new vessels? How long have they been there? Are they regressing? Are they progressing? So really important for us to document. With the Angio Ct, we get depth encoded images, so superficial, deep, and avascular zones. And we can just make out there's some redness in the superficial area at the edge of the disc. So it's important for us to know is that the start of something. When we switch to the vitreoretinal interface, we can clearly see this is automated on the Angioplex, a tuft that looks suspicious there at the edge of the disc. So as we scroll through it on the B scan, you can see a tuft of new vessels at the edge of the disc. And as we come through it again here, you'll see, and it's got some flow in it, which is an abnormality. Any blood vessel with flow above there is abnormal. So that's an early new vessel. And it's important for us to document that so that we can look at them when the patient comes next time and compare if there's any change in them. And there's the vessel. This is a more advanced new vessels. There's a lot going on here, and there's some papillitis in a young patient. We can see, as I said, more abnormalities there, so some capillary abnormalities, some new vessels possibly. This is depth encoded and a really beautiful image. As we look at the B scan, we see the papillitis and these engorged vessels. But there are some new vessels across the cut there. You can see them with the flow. And then there's a neovascular membrane coming down. So, you know, this is really important to document because we need to start treatment for this patient. It can happen in some of these patients that they're asymptomatic until they have an event. So we really need to show them what their image is and document that before we start treatment and then as we go along. New vessels elsewhere. So here we see an area of capillary dropout, ischemia, and adjacent to that, some new vessels, tuft there. So again, we document it. We've got the B scan here. If we scroll through, we can see the thinning of the retina where there's capillary dropout. And then as we come through the new vessels, we can see flow above the retina. So that's a neovascular frond of new vessels. So we've documented that. We can monitor and see how they respond to therapy. Again, some new vessels we can see on the depth encoded image. As we scroll through it, we can see a neovascular membrane just above the retina with some flow in it. So again, very important to document this. We can do this really accurately without going to fluorescein angiography. And we need to remember actually fluorescein can cause leakage from these new vessels, and that can interfere with our ability to deliver PRP. So this is a really good way to document neovascularization. So as we said, documentation is essential for us, for the patient. We want to look at stability versus progression. You know, we don't automatically laser all new vessels. I showed you a very small new vessel at the edge of the disc. There are, based on the DRS, rationale to treat. So once we reach certain stages, we can discuss that with the patient and say, look, you were like this last year. HbA1c is not quite so good and it's progressed. We really need to start getting on with treatment. And so we can do that. You know, Angio Ct, as I said, is repeatable. So we can repeat it at every visit. Here we can see just at the center here is a small new vessel. And then we just document that carefully. We can see it on the B scan. And then we look at them about 3 months later. It's exactly the same. It's a small new vessel. We don't need to intervene yet. We do need to monitor that. So we can flag that up for a similar Angio Ct at the next visit. So that's a really nice way to compare. Diabetic macular edema, as I said, we're treating that more with anti-VEGF, and we need to just have a look at the vascular state of the retina before we start treatment. So here's some intraretinal cysts and fluid. Do we treat them, based on a structural OCT? Yeah, possibly. We know anti-VEGF is a good treatment. But when we look at the Angio Ct, there's a lot more to the story. There's some central macular ischemia, some a little bit further out. And so this will affect the retinal function. It's important to tell patients these sorts of details because then their expectation is realistic. Not all patients gain X letters. And these are long courses of treatment for years. And so we need to be on board at the beginning. If they're not seeing a good response, they may be disappointed. Whereas if you can frame it well early on with Angio Ct images, then that's very useful. Here we can see a map, a fusion map, density of both eyes, and we can see the capillary dropout, the irregular FAS. And just showing these to a patient, they know what a normal retina looks like, and they know that this is not quite normal, and they'll become familiar with these images. As I said, we can repeat them sequentially, and we see them for a long time. If we scroll through, we can see very thin retina there, temporarily where there's ischemia, and then at the center as well. Here's another case, intraretinal fluid, cystic. There is some RPE disturbance. This was an older patient, so we considered whether to treat them, and we decided to go ahead with some anti-VEGF injections for them. This is on the left prior to treatment. And then as we look at the image there, we can see that they did respond well. The edema has reduced. There is some RPE disturbance, and if you look closely, you can see that's a sort of a PED that maybe have a vascular element. So we looked at the Angio Ct. We can see an abnormal vessel here. Again, depth encoded. We can see superficial to deep, and the vascular area in that little tuft there that you can see at the edge of the FAS. You can see that there's a vessel that's red. It goes green, and then there's a component of it that's blue. We zoom in on it there. So that's the same vessel that's tracking down through the retina. And then we see it on the avascular slice. This abnormal vessel, if you look at the PED when it comes through, the vessel has dipped down into the retina, and you'll see there's some flow across that as well. Here we go. So if we look at the flow there, we can see there's flow coming down through the retina and to the RPE. And here we see it. So that's a, diabetic patient who's elderly. That can happen for sure. They've got some RPE disturbance, but they've had a RAP lesion develop over time. So it's important to discuss that there could be co-pathology going on with this patient. Retinal vein occlusion. Here's a large amount of edema. Certainly anti-VEGF is a good option. If we look at the Angio Ct, we can see that it's an inferior hemiretinal vein occlusion, and there's significant ischemia coming up towards the macula. So it's important, again, to discuss treatment options with the patient, and that they will need regular monitoring and manage what they expect from this course of treatment. Here we look at the Angio Ct, we can see that increased capillary spacing and ischemia. Here's a patient who was pregnant, a young lady who had a branch retinal vein occlusion. We are cautious with investigations and treatment. So we didn't want to do a fluorescein. Patient didn't want to have a fluorescein, understandably. And with the Angio Ct, we're clearly able to show the degree of superior ischemia there. And when there's ischemia, we worry about adjacent to that, could there be neovascularization? So we perform the Angio Ct. You can see as we scroll through the ischemic retina, and then at the junction, there's a new vessel that's grown up there. So that's important. We were able to document that. We didn't need to do a fluorescein, and we can get on with performing laser treatment to prevent that getting worse, as vascularization can progress in pregnancy. There's the vessel dipping down. Next case is a retinal artery macroaneurysm. You can see it on the on FAS and on the Angio Ct there. And if we look on the left side of the screen, the structural OCT shows us that there's some fluid there. The Angio Ct shows us the aneurysm, and the depth encoded image also shows us that. So if we scroll through it, we can see the vessels superficially lying with a good amount of flow there through it. So that's a Angio Ct, and we can see the fluid in the retina and subretinal. So very important for documentation. You may go ahead and offer some treatment for this patient, and we want to look at how that changes with time. Here's the large aneurysm in a B-scan section. Other things that we find useful, this is the CARS image, and we really benefited from this in terms of patients being able to document the degree of sickle cell retinopathy and then to look at them sequentially for change. So that's the service we've developed, thankfully, with the really nice technology of the CLARIS from Zeiss and the Angio Ct. We're able to offer a new screening program here at Moorfields. So it's very important to have that discussion with patients about sickle cell and how it can affect the retina. Even if we're not going to offer intervention, it's still important. Here we can see on the Angio Ct, we've got an irregular phase enlarged, and so that may affect the vision. If we look at the angioplex superficial slice and the B-scan, we can see that temporarily there's thinning of the retina. So although this patient may not be having problems with their vision, we can discuss this with them and their hematologist. So they're the hematologists, the patients, and we have been really pleased that with Zeiss we've been able to offer this screening service with this quality imaging. So those are the main cases that we wanted to talk about. I hope you will have a think about why we really think it's so important for patients to be able to document things, and for us. So these are a few of the things we wanted to say, really. I think it engages patients well so that they can understand their diabetic retinopathy, where they are, whether there's progression, and why that might trigger a rationale for some treatment. As I said before, some of these patients may be asymptomatic till late on. So it's very important for them to understand why we're saying we want to do this intervention, which may be prophylactic in nature, so may not help them immediately. And then it allows us to document what stage they're at so that we can monitor them in the clinic, and progression so that we can talk about rationale for treatment. OCT angiography in macular edema, whether it's DMO or retinal vein occlusion, forgive me, DME or retinal vein occlusion. Why is that important? Well, it's a vascular disease, so we need to look at the capillaries, document whether there is macular ischemia, which may affect outcomes, and have that discussion with the patient. Not all vein occlusions or macular edema are the same, and it helps us feel confident. Macular edema can be a pathology that comes out of a number of diseases, so it helps us really identify in that case that we saw there. So thanks very much to Kevin and Raluca for allowing me to talk. As I said, it really helps at this time for us to be able to discuss these cases, and hopefully we can discuss it some more.
Thank you again for the presentation. This is another great one, and we are getting a bunch of questions, including my good friend, Dr. Pizzamente. So as I called him out for questions, and he responded. So good question it is, and actually, I think we spoke about this the other day when we talked. So is anti-VEGF, is treatment something you do with someone with subtle neovascularization at the disc and severe non-proliferative PDR, but not neovascularization or what you consider proliferative diabetes?
Go ahead. Well, from our point of view, for diabetic macular edema, we can use anti-VEGF. So a lot of those patients do have severe ischemia, and it may have a benefit. But we still use laser for peripheral ischemia. We think it still has a place. Once the laser's done, then we can relax a little bit and not be so worried about the ischemia driving VEGF and new vessels. In some places, anti-VEGF is coming in following large trials for PDR, but not yet for us. Hopefully it will in the future. but certainly for macular edema, we do consider ischemia, and where there's central ischemia, we may have peripheral ischemia. So very important for us to image that before we start treatment with anti-VEGF.
Okay.
So my view is very, very similar. So laser is very useful, and I know that people are worried about visual field loss and lots of other complications. But in most cases, you find that if someone has been lasered properly, you don't have to see them very often afterwards, unless they develop macular edema as well, which then you can treat with anti-VEGF. So it's sort of a balance between costs, opportunities for treatment in different countries, and also the economic standing of sometimes the patient, not just the health system. Laser is a definitive treatment. So even if at the moment, so you create scars and you create cell death. So you have to be careful as to what you say to the patient. But in many cases, you might be able to combine it. We have been combining it, especially during the COVID era. You give an anti-VEGF, pupil dilates within, when very quickly in a week or two, when the ischemia is a bit better, and then you end up with a much easier laser treatment. So you try to minimize some of these times that patients spend with you.
Yeah, I just, last week with Sakline and Ricardo, two of our fellows, we had a patient whose macular edema had got a lot worse in one eye. So they did need anti-VEGF, but in the fellow eye, they had severe peripheral ischemia. So, particularly with COVID, and we talked about second wave, at least, the eye with peripheral ischemia, but no macular edema, we're concerned about that. So once the PRP was on, we can relax, and even if there is a second wave and we may not see the patient for a while, the PRP is durable and that effect is still there. So it's still a very good treatment, particularly now, actually.
And so we have a bunch of questions. We have running out of time, but we'll go a few minutes over. I'm not afraid of that. But I do want to put up our polling question again to see how that changed from earlier on. So in the future of diabetic patients, how do you plan on using it? So we'll see how that changes after your presentation. But while they go ahead and answer that, one of the questions, again, we already answered, how you can do structural imaging of OCT for diabetic macular edema. Why do the OCTA? You actually had that as your, that question was asked early in the presentation, and you answered that at the end. But the other question is how often do you perform, or do you recommend performing OCTA on those diabetic macular edemas?
So for me, all patients who we're thinking of starting an intervention on, so at baseline, I think it's a bonus. It does take a while to adjust to it or to learn what you're looking at, but you've got the structural OCT there, but in addition, you've got the Angio Ct. So it helps identify those patients who may outcomes may be a little different, may need more attention. And then, you've got the baseline. So as I said, these patients stay with us for many years. So, down the track, a year, 2 years, 5 years, you'll have a baseline to compare with, to look and see what's been happening. So all of the patients, really, if we can.
Yeah, and also in cases, so you do it at baseline. You can do it once a year afterwards if you want to for monitoring, or if there is a surprise. So outcome. So either sometimes some patients that you didn't expect to do well do amazingly well, and then you can see if you just misjudged the situation, or some patients do really quite poorly, and you find that they developed a huge amount of a large foveal vascular zone, and so you can help it can really help the discussion with patients either way of surprises.
Yeah, the other thing is, as we said, these patients' retina may not be completely normal. So if you've got a baseline scan, if something else comes along down the track, as we saw in one of the cases, you can easily, patients can be diabetic and elderly. Later on, they can develop a CMV. So you're not looking at a normal OCT in the first place. So if you had a baseline to compare that with, if something happens, as Tunde said, down the track, you're comparing with that patient's baseline. So it's very useful. I think all patients, if we can.
Yeah, and while you mostly both of you showed images from your angioplex units, I'm curious how you would answer this question here is, does OCTA have a clinical utility in the managing or the imaging of choroidal vascular disorders?
Not in a form that is easily available for people at the moment. Also, I think most of our patients are in the retinal vascular area, so it's quite difficult to image some of the other patients. No, we don't, and I think we're guilty as charged. Sometimes you use it more in something that you know more about, especially in a routine clinical practice.
Okay.
I agree with Tunde. You know, I'm a medical retina, but fortunately for me, on a Monday morning next to me is Carlos Pavese, Mark Westcott, Angela Reese, and people. So for the uveitis people, I think it really will have a good function, particularly with the swept source OCTA, which is what I think you're alluding to. Yeah,
it's kind of where I was getting at. The swept source, I think you're going to see more of it. You can see, obviously, we have up on the screen here the next webinar, which is on the uveitis, and we'll show some examples of that.
Yeah.
So let's just get a few more here before we let you go. I know we are a little bit over. Let's see, what treatment, let's go in here. Here we go, it's a great one here. So we can now identify these cases of ischemia that we weren't sometimes picking up on others. So what are you doing in treating for these macular ischemic patients?
Well, I think the main issue is that sometimes they don't need any different treatment than what you would be giving them anyway, but your discussion with the patient will be significantly altered. So if someone's foveal vascular zone is as big as the macula, very, very large, even if they have currently good vision, they're very unlikely to keep that good vision, even if we give them anti-VEGF. Or do the PRP or anything. So you have to be able to discuss it with the patient. So you use it a lot of the times more for monitoring. At the moment also, we don't quite understand as to when seemingly vessels return, is it a real return, or was it just an imaging problem before? Or was there so much fluid that we just somehow couldn't get the imaging done? So I think it's also very good for increasing our understanding as to how far we can push some of the therapies that are currently available, and hopefully that are coming online soon enough to have the patients with some of these ischemic problems as well.
Yeah, I agree. You know, just as much information as we can. So good for patients, and also with future treatments, we'll need to be a bit more aware about degree of ischemia.
Yeah, so we'll end on this question. I'm not sure if this is more of a technical, maybe your photographers for this one though. What's the shortest scan time to obtain an OCTA during COVID times, worrying about exposure around patients?
3x3 for both eyes, a couple of minutes, really. So yeah, for a CNV, that would be enough for an AMD CNV.
So that's a much shorter time than you would do for a fluorescein.
Sure.
But that's certainly improving. I've noticed even in the short time we've been with the Angio Cts, the scan times are coming down. You've got the 6,000 coming. You know, so I'm really impressed by the improvements that are coming. And back to your question at the beginning, that's probably the most important, as you said, for the photographers. The more accurately and quickly we can do the scans, the more patients we can image, and that's a priority in a busy clinic.
Well, I appreciate everyone's attention out there online. I definitely appreciate your dedication to getting these presentations together and spending the time with us. We look forward to seeing you in future webinars, and someday we'll actually get together at real meetings again rather than Zoom. But until then, I appreciate everything you guys do for the community, and I look forward to seeing you guys soon. Thank you again for your time.
Thank you for listening. Thanks to them.
Thank you, everyone.
Cheers.
Thank you.